Thank you, Robin. Good afternoon, everyone. And now I hope you can see my first slide with the title for today, Availability for Learning the Forgotten Senses. It's a great pleasure for me to be doing this because the Idaho Training Clearinghouse has been a very helpful resource for me for at least a decade. Many of the webinars there I've watched time and again and learned from. So it's a great honor now for me to be lined up with that sequence of predecessors. I'm a deafblind specialist. I've been in deafblindness for 35 years, but one of the things I've learned very strongly is that if it's good for children with deafblindness, it's good for everybody. And if there's one thing we all share, it's that none of us has perfect sensory perception and perfect sensory processing. And that will be very much apparent in these three webinars as I talk. Deafblindness, over the 35 years I've been in the field, has become much more complex. We've seen the population of children increase in their complexity, in the really multiple nature of their medical issues, and in the amount of teamwork needed by both medical and educational and, if you like, social work services to support the children and support the families and support the teachers and classroom staff working with them. So although I talk a lot about children with deafblindness, remember that probably almost everything I say will have resonance for children, for your children, if you're a family member, or for children you are working with or will be working with in the future in the educational setting. My overall title, What Does Follow the Child mean? The idea, the advice to follow the child comes from Jan van Dijk, who was one of my gurus. I will talk about gurus in a future webinar. Van Dijk died, unfortunately, 2 months ago. So none of my gurus is living anymore. But he came up with the idea of following the child. And I've chosen that as the overriding title because all three of these webinars overlap to some extent, and they all follow one from another. So today I'm talking about all the senses, and especially the senses we might not know about or have forgotten about. And then next week I'll be talking about assessment. Although everything I talk about is assessment, I'll be looking more in a more focused way at assessment approaches. And then in the final webinar, I'll be focusing on the two big issues that people present to me as an advisory teacher again and again. And one is self-stimulation and the other is self-regulation. And we're finding those, especially self-regulation, have become overwhelmingly challenging for people in the educational field. So although the webinars are discrete, they also go together very much as a series. If I have one simple overall message from these three sessions, it's a couple of points that I can say them simply, but they are challenging. First of all, observe children. Notice what they do and how they do it. Respect what they do. Interpret what they do and share your interpretation with others. And then use that information in your instruction, in your teaching. I will occasionally mention charge syndrome because it's now the biggest cause of congenital deafblindness in the developed world. Specific cause. It's a genetic condition, and the numbers of children identified and surviving is increasing quite an alarming rate, so that now every state in the US has a deafblind project, and all of our projects are having to learn about children with charge. And they're a great model for us to learn from, because charge syndrome is the most complex condition that we know, and the children are the most multisensory impaired. So that's just by way of a slight background. And as I just said, if I talk about deafblindness, don't turn off because you're not working with a child with deafblindness. Far from being separate and different from mainstream education, good quality deafblind educational practice in assessment, instruction, and program evaluation offers significant lessons to all students and to all educators. So if I say deafblindness, you might want to think complex disability or complex multiple disability. Most people focus on the child's disabilities, but close attention to their abilities can reveal more about the difficulties they face, as well as the strategies they use to function effectively. I think we are very inclined to dismiss a lot of things children do, especially when they're younger, but also when they get older and when they're in their teens, to the extent that we don't even see what they're doing. And if we do see it, it tends to be irritating because we see it as distracting or as worthless or as stigmatizing. And I think if we can get over those revulsions, really, and focus more on what the children are doing, and as I said at the beginning, interpreting what that means and what that tells us about them, then we have a very valuable gift from the students. Everything that children do has meaning for them, and that's a really important point. Nothing is random, it all has meaning. It all comes from somewhere. And the first obligation on us teachers is to ascertain the meaning, or at least come up with a good guess, maybe in teamwork with colleagues, and then act on that and see if we can discover whether we're correct in our interpretation or not. One of the most important early assessment questions we can ask the child or of the child is, what do you do? And that is a question that doesn't feature a lot in assessment approaches, in my experience. As teachers, we're very good at asking, what can you do? But I think that question comes a little later. Trying to extend the child, trying to test them to see where the baseline is. Can we get to a threshold where their skills extend and then stop? That gives us a teaching point. But before we get there, I think just observing a child and saying, what do you do? And what does this mean? And what does this offer me in terms of understanding you better? That will give us a very, very effective base to carry on moving towards getting that baseline sorted. Deafblindness now involves many more senses than just vision and hearing. It's not enough only to consider the tactile sense as a compensatory channel for functioning and learning. The days when I worked with children who had an eye defect and sensory neural hearing loss, but otherwise everything was okay, those days are long gone. And there are some of those children around, but on the whole, it's way more complex than that these days. And it's for that reason that in my country, in the United Kingdom, we abandoned the name deafblind and we came up with the name multisensory impairment back in the very early 90s. This slide is taken from my degree certificate when I got my deafblind teaching credential at the University of Birmingham in England. And you will see at the bottom, my degree is in special education, multisensory impairment. And in the UK, MSI is a very well-known and widely accepted term. So I would be called an MSI teacher rather than a deafblind teacher, because it's likely that many of the child's senses are going to be impaired and affected. This is my list of senses, and I choose my words carefully. At the top, congenital deafblindness increasingly involves problems with the perception of vision, hearing, touch, proprioception, temperature, pain, vestibular, smell, and taste. I'll say a little bit today about smell and taste, but I really want to focus on the proprioceptive sense and the vestibular sense as the key, crucially important senses that get overlooked. And although I call them the forgotten senses, they may not be forgotten because you may never have known about them. I was in the deafblind field quite a long time before I discovered these senses, and I really wish I'd known about them long, even before I came into deafblindness in 1983. It would have been helpful. You'll notice pain is there. People tend not to think of pain as a sense, but it's an important sensory system, and it operates in the same basic way as all the other senses. Stimuli are conveyed by the receptors of the pain receptors to the brain for processing, and then the brain has to make a decision depending on what information it's getting. So do remember that pain is part of your multisensory system. I was working in Atlanta recently, and when I got to the airport, there was this advertisement, a new advertisement for Turkish Airlines was up very prominently on a huge poster. And it just made me sigh because it promotes the idea that we have 5 senses. And I'm sure you were all taught as children that you had 5 senses. And across the top of the picture, it says, see, hear, taste, smell, touch. And then it goes on and on. If you go to their website, the sights of Turkey, the smells of Turkey, the tastes of Turkey, and so on. And I always see these 5 senses and I think, no, you've got to say there are at least 7. And why not include pain as well while you're at it? Because they're all important. And in some ways, they're more important than these more conventional ones that we all know about. All the senses are designed to work simultaneously, supporting and confirming each other, but also at times in competition with each other. We have to develop the ability to modulate the information coming from all our senses simultaneously so that our brains can focus on some sensory inputs while inhibiting and ignoring others in a constantly shifting pattern. When we develop this ability, it's known as sensory integration. If any one sense is impaired or missing, the other intact senses will become more important and acquire a compensatory role, but initially they will be more challenged as well. If more than one sense is impaired or missing, the task of achieving and maintaining good sensory integration will become increasingly difficult. And that will be very much a theme, again, of these 3 webinars. Here we have a diagram which is called the pyramid of learning. And at the bottom, the foundation, you have the central nervous system or the brain. And then the first level, the floor, as it were, of the pyramid is the sensory systems. And then above them, you have sensory motor development. Above that, perceptual motor development. And at the very top, cognition and intellect. And the very peak of the pyramid, the crème de la crème, is academic learning. And many people think that that is what education is all about, academic learning. Those of us in the know that academic learning is just a part of education, not the all-consuming goal of it. And for teachers, it's often a problem because people like politicians and bureaucrats only think about academic learning and tend to devalue children who are not actively involved in academic learning or are not involved at a level that they deem to be appropriate for the child's chronological age. And what this diagram shows is that academic learning depends on an awful lot of other things which have to be operative and developing ahead of academic learning if academic learning is to take place and is to be supported. Now, the senses are at the very bottom deliberately because they are the foundation. And again, a theme of these webinars will be this idea that the brain depends entirely on the senses in order to function, in order to grow, in order to make decisions. And if you look at the senses on that bottom level, you'll see that they're divided into two. And the very bottom level has touch, vestibular, and proprioceptive senses. And then smell, vision, hearing, and taste are the next level up. And that's quite deliberate because those three senses on the bottom, touch, vestibular, and proprioceptive, are the foundation on which those other senses develop and are based. And that's why I'm talking in particular about the vestibular and proprioceptive senses today. I think I have a few more very wordy slides for which I apologize. This is from an article I wrote a long time ago now. In the field of deafblind education, we have traditionally, and for obvious reasons, focused on the senses of vision and hearing and on strategies for improving the use of any residual function that may be present in both of these distance senses. At the same time, we've also paid some attention to the sense of touch as an important information channel that can help to compensate for loss of visual and auditory information. The other sensory systems, the taste, smell, proprioceptive and vestibular senses, have received very little attention from us, even though together they provide the essential foundation upon which all of our higher vision, hearing, and touch skills are based. These other sensory systems also offer valuable channels to the children for learning and to us for teaching. And then another quote from a different article. We do know from experience that difficulties with vestibular and proprioceptive functioning in particular always need to be addressed first if the children are to make the best possible progress in using touch and residual vision and hearing effectively. Knowing about these other, I would say, forgotten senses will give you a different way of looking at yourselves and at other people, and should also help to make children with deafblindness less puzzling in their behaviors. I'm going to skip the next slide and move on to a quote from Krishnamurti. I don't know if any of you are familiar with Krishnamurti. He's not talking about deafblindness or even disability, but I quote him quite often. I'm talking an awful lot in these three webinars about bodies and about movement and about posture. And I really like this quote. But if one observes, one will see that the body has its own intelligence. It requires a great deal of intelligence to observe the intelligence of the body. When I came across that quote, it jumped out at me because I've been trying all my career to develop the great deal of intelligence needed to really observe the intelligence of the children's bodies, what they're doing, how they're doing it, and especially why they're doing it. And that's why I'm giving these webinars today. I recently found this photograph. I came into the deafblind field in 1983, and this photograph was taken almost 1 year later in 1984. This is a young man, a 12-year-old called Donald, who I worked with for a couple of years. He had congenital rubella syndrome. And we're out in the garden at the family centre where I worked in London. And what I discovered, even though I didn't know about the proprioceptive and vestibular senses at the time, I discovered that Donald, after a long, long session of rolling and bouncing and spinning, was actually more attentive to the environment around him, more attentive and responsive to me, sat still much longer. He was much less distracted, and we had much more effective sessions of formal teaching in the classroom if we went through this kind of large motor activity 2 or even 3 times a day. Of course, in England, we couldn't do this out in the garden much of the time because of the rain. But this was just one way that I found of giving him this very strong diet of vestibular and proprioceptive input to get him in a better place and more available for learning. Now, of course, I look back 34 years on, and I think how wise I was to have come up with this idea, but what a shame it was that it was still another 6, 7, 8 years before I ever heard about these 2 sensory systems that I'm using in the picture. Now, I wasn't sure in this session to include information on smell and taste. They're a little bit of a side issue to what I'm focusing on. I made the decision the other day that I would say a little bit about them, but there are handouts to go with this webinar, and 2 of them are articles that I wrote some time ago, one about the sense of smell and one about the sense of touch. So if you want more information, you can access those, and I will go through things fairly quickly. So first of all, the sense of smell. Some children are known as anosmic. In other words, they have no sense of smell at all. Some children show no awareness of smell, even though that particular sense may be intact and working. Some children give very clear evidence that smell is an important sensory input for them. I think of children I've worked with in the past who, when they meet someone, when someone comes into their field of awareness, the very first thing they do is grab for the person's hand, pull it up to their nose and sniff it as a way of identifying who this person is. And for those children, that seems to be more reliable than looking at the person, listening to the voice, or exploring them through the sense of touch. So in a situation like that, smell can be particularly useful. I also know children who are very, very low vision, profoundly deaf, who every time the parents report, every time they go to the hospital, they get terribly upset, almost as soon as the family walks into the hospital. And again, we're assuming in many cases that there's a particular smell in the hospital that very quickly evokes a memory of previous visits and all kinds of unpleasant activities that happen there. The usefulness of sensory channels like smell and taste might be increased as long as the inputs coming through them are consistent, clear, and meaningful for the child. And that is very difficult to manage in practice. So as I go through the next few slides, you'll see me, in a way, warning you off putting too much emphasis on smell and taste as part of a teaching program. The sense of smell is particularly unique because all our other senses, information goes to the limbic system in the brain through the thalamus. The thalamus is a kind of filtering processor, but sense bypasses the thalamus completely. So smell is the only sense that actually really directly connects our brain to the environment around us. And it's for this reason that smell very quickly and vividly evokes powerful memories and strong emotions. And I'm sure everyone listening has at some point come across a smell that they haven't come across for a long, long time, maybe even since their childhood, decades ago. And that smell instantly pulls your memory back to your grandma's house or your primary school classroom or whatever. Loss of smell can be caused by a whole range of things. Advancing age is a very significant cause of impairment of the sense of smell. Disease of the nasal passages and the sinus can impact smell perception. Upper respiratory tract infections, if you have a cold or influenza, your sense of smell more or less disappears. And interestingly enough, your sense of taste also disappears, and food gets to taste pretty horrible. If there's particular kinds of brain trauma or damage to the cranial nerves, the pair of cranial nerves, number 1 or number 5, then that will impact on smell perception. Some neurodegenerative diseases like Alzheimer's disease result in a loss of sense of smell. Certain medications, and if there's specific damage to the olfactory bulb. The olfactory bulb is at the top and the back of the nose where the smell receptors are based. And children with Charge syndrome, for example, when that area of the face is scanned, it shows that the olfactory bulb is either missing or is unusually small or very malformed. So there are some conditions where the sense of smell is very specifically impaired. Working with the sense of smell, as I said, is tricky. If there are existing smells that are an inherent part of the child's life, then see if you can strengthen them, if possible. You can also draw the child's attention to the smells in a way which helps them to connect the smell with the upcoming activity. You can use activities which will encourage the child to seek out smells more consciously and deliberately. And one example would be, for example, if you're doing a regular massage with the child, using a massage oil with some, for example, essential oil of lavender added to it, so that the lavender smell can become a whole extra label for the massage session. And it can go with using the same container, which feels the same with the oil, using the same colored towel if the child has visual perception. But the smell can be used very deliberately as an extra piece of information. It's good to remember that smells remain perceptible for a long time in the atmosphere. I went to a school in England a very long time ago where the teacher very creatively had come up with the idea of buying 6 different aerosol sprays. There was pine, there was lemon, there was lavender, I can't remember the others. And she would use them to mark specific activities through the school day. But with an aerosol spray, obviously you spray the air in the room, and that smell is going to stay around for the rest of the day. And I was there to observe for the day, and by lunchtime, I remember feeling quite high and realizing that probably every child and every adult in the room was high because of all these chemicals that were swirling around in the atmosphere. Really not a good idea. It's also good to remember that the sense of smell tires very easily, and the nose begins to lose its sensitivity after it's been exposed to 3 or 4 different smells in fairly rapid succession, say over a period of half an hour or so. So the deliberate introduction of new smells should be done consistently and appropriately only after careful deliberation. This is a path I wouldn't want to go down unless there were very limited other pathways available, or unless the child had shown a specific interest in smell in some way. And then the sense of taste. We categorize taste as 5 distinct groups. And if you can find diagrams of the tongue and the oral cavity, the mouth, where the taste buds are located, specific areas of the tongue and the oral cavity are receptive to specific taste groups. We have sweet, salt, sour, bitter, and umami. There used to only be 4, and umami was added several decades ago. Umami is a Japanese word which means savory, and this is often described as the smell of cooking bacon. It's a smell associated with proteins and the amino acids that are produced when we consume proteins. Sweet, fairly obviously, applies to carbohydrates like sugars for direct energy, and glycogen, which is how we store energy in our bodies. Salt is important for our ability to absorb water into our bloodstream and to hydrate effectively. Sour is found especially in fruit, and interestingly enough, this is the taste group often more even than sweet, that is particularly appealing and exciting to children. And you probably remember going back to, I'm asking you to go back to your childhoods a lot this afternoon, the kind of candies that are very sour, that when I was a kid, we had a candy that was called sour lemons. And the first time you put one in your mouth, you did actually slant your eyes and purse your lips. But then you'd have another one and another one. And then bitter is found in many, many foodstuffs. The examples I've picked out are coffee, cocoa, olives, cabbage, dandelion, chicory, quinine. This is a particularly important taste group to perceive because it's the main group that are toxins, the toxins to human beings are found in. Taste drives our appetite and protects us from poisons. It has that double function. And as I've already implied, taste is very closely linked to the sense of smell. If your nose is blocked, you tend not to taste anything, as when you have a bad cold. There are multiple neural pathways transmitting taste information from the tongue and the oral cavity to the brain. So it's quite unusual for anyone to have no taste at all. And what I've discovered over the years, many, many children with significant levels of multisensory impairment need very strong smell and taste inputs to perceive them. And you get to the stage where you meet children who will eat almost any food as long as it's smothered in chili sauce or tomato ketchup, for example. They like lots and lots of sugar in their drinks, and so on. Previous visual, auditory, tactile, and smell experiences can become very attached to taste sensations and memories, and these stimulate strong taste anticipatory expectations. Smell and taste are the 2 chemical senses, and it's good to remember that an awful lot of what we think of as taste is actually a combination of temperature, texture, and mostly smell input. Now I'm going to move on to the proprioceptive sense and then on to the vestibular. The proprioceptive sense is the sense that helps us to plan and position and grade our movements without having to look to see what we are doing. This enables us to move automatically. You think about walking. Once you've mastered walking, you do not have to look consciously to see where you are putting your feet, unless you're walking in the dark, or unless you're walking on jagged rocks, or unless you're walking between lots of broken glass or lots of dog poop. Then clearly vision comes into play. But normally we walk on an automatic level. The word comes from two Latin words meaning an awareness or a feeling of your own self. And it's generally considered to be one part of a very big, complex sense of touch. I like to call it internal touch. It's how you can feel your body without actually touching it with your hands. The receptors are based in the muscles and joints all through the body, and they are responsive to three things: to stretching, compressing, or twisting of the joints and the muscles. So anything that stretches a part of our body, or compresses part of our body, or turns and twists part of our body that's going to send proprioceptive messages to our brain telling us what's happening to that part of our bodies. And if this sense is working normally, our brains are kept constantly aware of where all our body parts are and whether they're moving or not. And you see two old photographs of me there demonstrating a game which I'm sure you've all played, where you close your eyes and you isolate the proprioceptive sense. So no other sense is helping you. And then you bring your right index finger forwards and touch it on the end of your nose. And if you don't quite get to your nose the first time, you usually get there the second or the third time. So this is a sense you can train. And it's the proprioceptors in your trunk and your neck which are telling you where your head is, and in your right shoulder and all down through the arm, through the elbow, through the wrist, and in the hand are telling you where that finger is and where it's going. And you touch your nose gently rather than punching yourself in the face, again, because your proprioceptive sense is helping you to grade the movement, to use just enough energy appropriate for the activity you're trying to do. If you then move above your body, like the second picture, and try and touch your index finger on the other hand's thumb, it's much more difficult because you've moved right away from the proprioceptors in your trunk and in your neck, and you've kind of flown into outer space. And again, the more you try this, the better you get at it. Proprioceptive perception goes wrong because of significant injury, especially broken bones or torn ligaments and torn tendons, orthopedic surgery, arthritis, in effect stops you feeling where your limbs are. If there's cerebral palsy or some other similar kind of brain damage, or basically any kind of abnormal muscle tone, then it's going to be difficult to feel proprioceptively where the body is and what it's doing. We all need a range of normal muscle tone in order to feel where our body is effectively. If the muscle tone is too low or too high, if the muscles are too stiff or too floppy, or if you're like those children who can only alternate between the two extremes. They go into extreme backward extension with high level spasticity, but then if you can bend them in the middle, if you can break the extension pattern, they go to the other end of the extreme, they become very low tone and they collapse forwards. And those children are going to have significant problems feeling where all the body parts are. Poor circulation is the one that we're all familiar with, where you sit on your leg on the couch watching television. Somebody rings your doorbell and you get up, and because we've cut off the blood supply to the leg, we've lost the sense of touch and the sense of proprioception. We talk about the leg going to sleep, and it's very difficult to walk on it until we can get that sensory perception back. And what we tend to do is give ourselves very strong proprioceptive stimulation through the leg. We stamp the leg, we shake it around, we slap it, we rub it and massage it with deep pressure on the muscles. And gradually the sensation comes back. Poor proprioception is commonly associated with touch, vestibular, and vision difficulties. And I'll say more about that whole issue towards the end of this webinar. And like all our senses, lack of use can be a big, serious problem. If you're not moving much, if you're not putting pressure through your limbs, if you're not compressing and stretching and twisting your limbs on a fairly regular basis, then this sensory system is going to atrophy and eventually stop working. So it's really important to remember that if the child isn't doing these things for themselves, we need to do it for them and with them. When this sense is not working, you'll see a whole range of common outcomes. First of all, if you put the child down, face downwards, they often get terribly upset. Gravity is a big problem for them. And when they're face downwards, their face is kind of squished into the floor by gravity. So they're very reluctant to go down, face down. And it's very hard for them to push up on the hands and arms because they don't feel those parts of the body very effectively. And it's not safe for them to push their head and their upper trunk up from the floor because they're likely to crash down. Equally, if you're trying to get them to stand and bear weight on their legs, they have the same insecurity. They often will collapse, or they will lift their knees up to their chest and start to cry and turn blue and get terribly upset. It's hard for them to feel and control the joints in the toes, ankles, knees, and hips, and in the spine to maintain good vertical stability against gravity. They often prop. These are children who lean and prop an awful lot. And we all lean and prop. But for these children, propping like that is probably essential for various reasons, which again, I will go into in a short while. When they are weight bearing, you often find a characteristic pattern where they stamp their feet or slap the feet repeatedly on the floor when they're cruising or walking to maximize the tactile and proprioceptive sensation. I call this feeling the feet. They also often insist on being barefoot, again, to maximize that sensory information coming through the feet. But then later on, when their mobility, their independent mobility is improved, you often find they move to high tippy toe walking. And if you try this yourself, you discover very quickly that going on to tiptoe maximizes the pressure input through the feet, the ankles, the calves, the knees, the thighs, and the buttocks. It's a different way of feeling the feet. First of all, if you go up onto tippy toe, you've got your body weight on a much smaller area than when you stand with your feet regularly placed on the floor. So there's a lot more pressure going down through the ball of the foot. But also when you go up to tippy toe, the muscles in your feet, your calves, your thighs, and your butt all tighten up very dramatically, particularly in the feet and the calves. And the brain then gets much better idea of what the feet and the legs are actually doing, where they are and what they're doing. And because this is the sense that helps us to control and grade our movements, the children often appear very clumsy, poorly coordinated, and you may even see that they have their own self-taught correction strategies. I know children who have crunched their knuckles on the doorknob so often that they now put their flat palm on the door and then slide it towards the doorknob before they grasp the doorknob and turn it to open the door. The same if they're reaching for a glass or a cup on the table. Rather than fly through space and hit the glass, they will put their hand on the table and, usually guided by vision, will then slide it along the table until they can grasp the container. What they've learned is that flying a plane is more complicated than driving a car. Operating in 3 dimensions is more challenging than operating in 2 dimensions. And because this is the sense that helps us to grade our movements, you may find that they use too little force or far too much force when they're touching, patting, grasping, pushing, pulling things, lifting and placing things. They may often drop objects. They may often destroy fragile things because they crunch them too hard. These are not children you would give a raw egg to in the shell and say, go and give this to Mary. You know that the egg will either end up on the floor or the child will just squish it in their hand because they have to grip it really hard in order to know that that's what they're doing and that they've got it. I've worked with a number of children who were described to me as aggressive. And when I've gone in to observe, the children are simply using excessive force when they are touching people or grasping people's arms or putting things down on the table. And aggression is a misconception. It's a judgmental word that shows a lack of understanding of what the underlying problem is. And then something I'll talk about a lot over these 3 sessions, self-stimulation. Seeking strong pressure or stretching or twisting inputs to compensate for the fact that these are not coming in what we would consider to be a normal way. Some examples I've picked out: squeezing into very tight spaces, crossing or twisting the limbs tightly around each other, twisting a foot or a leg around the leg of a chair, binding the body parts with cloth or string or rubber bands, often very, very tight binding. I've seen children bind string around their fingers so the tips of their fingers turn blue because they're cutting off the circulation. It's so important to them to get this proprioceptive information coming into their brain from their hands. Pulling on the teeth or the lower jaw downwards, often with a very rhythmic pattern, grinding the teeth, which is one of the strongest sources of proprioceptive input that we can give ourselves, tapping on the teeth with hard objects, clapping the hands or flapping the hands. This is my favorite self-stimulation behavior. I'm a hand flapper. I'll talk about self-stimulation in 2 weeks' time. But in my experience, self-stimulation is seen as a very bad thing, where I see it as a very good thing in general. And hand flapping seems to be the most despised of all the self-stimulatory behaviors. It's often equated with cognitive impairment or mental retardation. It's also seen as an indication of autism, all of which is utter nonsense, of course. It's hand flapping. And hand flapping, apart from anything else, is a major source of strong proprioceptive input. It also, as I will discuss in 2 weeks' time, it's a major way of releasing energy which is building up too much in the body. If you observe when children flap their hands, observe before and observe afterwards And you might be quite surprised at the differences you see, demonstrating that the hand flapping is actually an adaptive functional behavior, not something they do just to annoy you. Leg swinging or kicking, hanging over a bar, either with the arms and hands or with the belly, jumping up and down, banging on the head, and hammering objects. I've got lots of photographs, which I'll be showing you in all 3 webinars. And originally I categorized them like this. I've now rather abandoned this, but you will see the pictures as we go forward. Before and after walking has been attained, we commonly see postures involving the head, the legs, bending and stretching, hanging, the hands, planking, propping, squeezing, and climbing. And I will talk a lot in the 3rd webinar about the concept of sensory diet. We all know that our nutritional diet refers to the food that we eat and the liquids that we drink. And we all know that our body has ways of telling us when we need nutritional diet, when we're hungry or thirsty, and what we need, ideally, if we have a choice. Those times when you need sugar, those times when you need salt, those times when you need something very chewy, those times when you just need a drink, those times when it has to be chocolate, those times when it has to include alcohol. My body tells me very clearly, and increasingly often, unfortunately, but not to the point where it's a problem. But I'm noticing a trend as I get older. So just in parallel with that, we have the idea of a sensory diet, which is the kind of sensory inputs that we need, that our body is telling us there's a demand for some reason. And the concept comes from the occupational therapy world. It has evolved from the work of an occupational therapist called Jean Ayres, who I will mention quite a bit, and in some details in 2 weeks' time. She didn't actually talk about sensory diet, but one of her colleagues, a Californian called Pat Wilbarger, I think was the first person to come up with the words sensory diet. And I like to look at what children do and say to myself, what kind of sensory diet is the child giving themselves through what they're doing? And that will come out, I hope, clearly from the photographs I'm going to show you. So here's the first photo. This is a 12-year-old who I just met the day of the photograph. He is completely blind, profoundly deaf, very low muscle tone. He has no effective vestibular system. He has Charge syndrome. He's not thought to have any smell or taste perception. So this is a boy with minimal contact between the brain and the body and the brain and the outside world. His parents have brought him to our family picnic, and his mother, he's not walking independently, with great difficulty, she's lifted him and she's supported him in very assisted walking over to the swing. I notice that he's very stooped, that his feet slide along the floor but don't leave the floor. When she gets to the swing, she pulls his hand down to feel the swing. He gives a scream and drops to the floor and curls up in a ball. His mother sighs and rolls her eyes and walks away. And almost instantly, the boy's hand comes up, explores above him to find the swing, and then with great determination, he pulls himself up and then carefully lays across the swing in the position you see in the photograph. This is a very, very advanced skill, given that the general level of this boy's development this day. I'm watching fascinated. Once he's hanging over the swing, he pushes slightly with his feet to make the swing move. And then he moves his body forward a little, pushes again, then moves his body back until he gets it in just the right position. And there's nothing accidental about this. He is meticulously planning his posture to get things right, and especially, I think, to get things safe. And as soon as he's in the right position, he pulls one arm out of his sleeve, and then he pushes it with the other arm into the one sleeve. You can't see that in the picture. The sleeve is very, very tight, and the boy pushes and pushes. And then when everything is right, he moves his feet gently and he swings. And I talk to the parents, and they tell me that what he's doing is very typical. If he can find things to hang over, he does. He likes to put both arms in one sleeve. He also, if you leave him long enough, is inclined to put both legs in one leg of his pants. And because I'm thinking sensory diet, I'm watching this and I'm thinking, what is this boy giving himself in sensory terms? What is his body demanding of him? And it's primarily proprioceptive input. Think of stretching, think of compressing, think of twisting. So where his belly is resting on the swing, you've got strong compression. His body weight under gravity is compressing against the swing. But his upper body and his lower body are stretching under gravity. That lovely feeling in the top half of his body of just letting go and stretching down to the ground, taking all that tension, possibly some pain and stiffness out of the body. And then you've got those two arms jammed in one sleeve. The sleeve is providing that strong pressure and touch information that's letting him know where his arms are. And then he's giving himself some vestibular input through this very carefully controlled rocking. So on the basis of that visit, we began to work with the boy. He wasn't in a great program, so we helped the family find a more appropriate educational program. We got an occupational therapist involved who was trained in sensory integration therapy, and she went in and did a very good assessment of the boy. And here he is, exactly 1 year later, at our next picnic. He's now in a much more appropriate educational program. He's getting deep pressure massage twice a day. He's wearing a pressure vest, and he has pressure cuffs around his elbows and his knees. He's going swimming once or possibly twice a week, and they've just started therapeutic horse riding on Saturdays. He's also been given heavier shoes, all of which has got the boy more available for paying attention to the environment around him, because he's no longer having to find ways to put his brain in contact with his body. He's no longer almost obsessed with getting strong proprioceptive inputs, because they're being provided through these other activities. And when I asked his mom if I could show these photos, she said, with this picture, I'd have to explain to people that this photo was taken on a good day. And I laughed and I said, but a year ago, he never had good days. And she laughed and she said, no, you're right, actually. She hadn't thought of it in those terms. So his brain has been made available for attending to the outside world in the level that's right for him. Here's a very characteristic leg posture. This boy is getting a pump feed at one of our picnics. You see the feeding tube is going to a gastrostomy tube. And because he's going to be sitting there for quite some time, he's not in touch. His brain isn't in touch with his body very well. He has very low tone, significant vestibular issues. poor tactile perception. He brings one ankle up on the other knee, which creates very, very strong proprioceptive and tactile information, telling him that his body is where his body is and that it's fixed and that it's safe. Here is a child who's not yet weight-bearing in standing, certainly nowhere near walking, and has come up with this entirely by herself. The behaviors I'm showing are spontaneous. The children are discovering these things for themselves, and that's wonderful and worthy of respect, as well as giving us crucially important information to help us be more effective in our assessment and our teaching. You can see what she's doing. She's getting up into a headstand, initially with 5 supports, 2 arms, 2 feet, and the head. And she's now advanced to the point where she can release her arms, and she's just got 3 points. And what she's getting is massive proprioceptive input coming through her head and all down her spine and then through the legs. We know that in early infancy, children's brainstem grows and develops in response to proprioceptive and vestibular input. And for that reason, young children are very receptive to proprioceptive and vestibular input. And it's something we give babies and infants a lot. We rock babies, we bounce babies, we swing them, we squeeze them. All those activities are a very normal part of adult-infant interaction. And then when the children acquire independent movement, they tend to move excessively. And if you've ever lived with a normally developing 2 or 2.5 or 3-year-old, you know that they move and move and move and move, and they never seem to get exhausted until the point where they just drop unconscious. And then they wake, and almost immediately they're giving themselves proprioceptive and vestibular input again. I believe children like this young lady have that need and are therefore driven to explore ways of getting it for themselves. Here's a younger child again, totally spontaneous behavior captured by the parent, because this is so paradoxical, given that these children resist weight bearing and are very, very anxious in supported standing. Here's an even more dramatic example. And if we think about high school physics, if you stand on your feet, you only have 2 points of support. If you fall, the last thing to hit the floor is moving the fastest and is going to hit the hardest. And that, of course, in standing would be your head. In this position, the child has 5 points of support, 2 feet, 2 hands, and the head. And if they fall, the head is already on the floor. The thing that's going to hit the floor hardest is the feet or the heels. So that anxiety is minimized. So it all makes sense, even though it looks very paradoxical, given that these children dislike weight bearing and standing upright against gravity. Here's a boy squeezing into an abnormally tight space. As his mother said, it's very, very difficult for him to get in there. But once he gets in, you listen to his breathing, and his breathing decreases and gets deeper and deeper and deeper. He's relaxing, he's chilling out, he's putting his brain back in better contact with his body. And here's a young man who has developed this skill to the point where he can now climb on a dining chair, get under the table in this position, and then gradually curl his body to raise his back until his back is pushing hard against the underside of the table. And then he exhales, gives a big sigh, and again chills out and reestablishes his brain's contact with his body. What can we do to help with these problems? Well, if you can get an occupational therapist, a physical therapist, and or an adapted physical education teacher, they would be the key professionals. And it's important that any advice and suggestions they give need to be implemented on a regular basis. They may suggest things like deep pressure massage or a brushing protocol, rhythmic joint stretching and joint compression. Some of you listening may be familiar with brushing protocols, a very specific brush, and the therapist will design a program where the child receives firm pressure brushing done in a particular way on particular parts of the body, a particular number of brushes, a particular number of times a day. And it's not enough to get the brush and just brush children in a kind of willy-nilly way. The therapist designs the program and gives very precise directions how we carry it out. And those brushing protocols are becoming increasingly used in special education settings, but not always appropriately, in my experience. The therapists might also recommend weighted clothing or pressure clothing, a heavy blanket across the lap when seated, heavy shoes, heavy bed covers. Acceptable binding, spandex clothing, which is now, again, increasingly being used, tight socks, tight gloves, wrapping in a blanket, and so on. The children will often ask as a game to be rolled in a blanket or a bath towel and rolled very tightly, and then maybe you even lean on them and do rhythmic squeezing. And we do know that swaddling babies, as in the picture, I was swaddled as a baby because I was born in Wales in the 1940s, and it was still very traditional to swaddle babies and to give that strong feeling of compression all over the body. There are specific exercises to improve proprioceptive awareness. I already mentioned that grinding the teeth is a major source of proprioceptive input. Chewing gum or chewy items can be recommended. And then things like swimming, horse riding, crash mats, climbing frames, trampolines, and wrestling, if these are not contraindicated, can all be used and really appreciated by the child. Swimming is good because, first of all, the challenges of gravity can be minimized when the child is in the water, but also as they immerse in the water pressure creates a much stronger sense proprioceptively of where their body is. And then the resistance of the water as the child moves their limbs, again, gives much more proprioceptive information to the brain about where the body is and what it's doing. Here's a young lady I know whose mother found these stretchy swimsuits on sale. She's bought one deliberately a little too small for her daughter, put it on very tight, and reports a remarkable change. Her daughter's much willing to stand and weight bear, has much better functional vision, and tends to be attentive in social interactions longer than usual. The mom had heard me present on this and sent me these pictures and said that the improvements in her functioning were quite remarkable. And it's a reminder that everything joins up. That's another theme of my 3 webinars. These are wrist weights, commercially produced, used by therapists. There are also ankle weights. The increased weight increases proprioceptive input through the limbs to the child's brain. You've seen these people in these body socks. Here's a real child I know having a session of stretching and compressing through his body sock. And here's a young lady at the bottom of the picture who's, as part of her therapy program, is receiving rhythmic compression. Her brother is pretending to help in the picture as part of the therapy program. If you're really interested in this, at this link, there is a 60-minute lecture on the proprioceptive sense by a neurologist, Tom Jessel at Columbia University, which I would recommend. The beginning is a little bit complicated because he talks about neurology, but then when he gets onto practical stuff, it's great fun to watch. I'm just drinking my cup of tea. Now, the vestibular sense, which is much more complicated. When I teach classes about this sense, this is the slide I usually begin with. And this quote is from a book about walking. The body teeters on the edge of catastrophe. And I like the phrase because it reminds us that postural insecurity and gravitational insecurity are very, very powerful issues. And we shouldn't be minimizing or ignoring them in the children with whom we're working. The vestibular sense tells us about the position of our head, whether our head is moving or not, and the pull of gravity. It tells us which way is up. It detects head motion, and there are very strong links with the eyes and vision and with the proprioceptive sense. This is what should be in the inner ear on both sides of the head, if everything is anatomically correct. At the top of this diagram, you see the cochlea, the organ of hearing, which looks like a big snail shell. And then everything below that is the vestibular apparatus. Just like the cochlea, all these structures are very small, very fragile. They are all hollow, filled with fluid, and lined on the inside with nerve hairs. And the vestibular apparatus in particular has two bulbs, which you can see in the middle, the saccule and the utricle, and then three semicircular canals. You can see two of them clearly, and the one labeled is actually meant to be sticking out towards us. And the saccule and the utricle respond to linear movement. One of them responds to vertical movement in a straight line, like being in an elevator. The other one responds to linear movement in a straight line in the horizontal plane, like moving forwards in a car or when you're walking. And then the semicircular canals in particular tell us about head position and head movement. And the three semicircular canals are aligned towards each other so that one is stimulated when the head nods, like saying yes. One is stimulated like saying no, when the head shakes side to side. And the third one is stimulated when the head moves in a diagonal position in either direction. And these together give us that sense of where our head is, what our head is doing, and are a major contribution to developing a good sense of balance. They're not all of balance, but they're a very important part of it. Jean Ayres, the occupational therapist, in one of her books, says this: the vestibular system is the unifying system. All other types of sensation are processed in reference to this basic vestibular information. The activity in the vestibular system provides a framework for the other aspects of our experiences. So this is a really, really important sense. In some ways, this is the big one. Why are there problems with the vestibular sense? Well, if you research the causes of pediatric vestibular disorders, it's quite startling when you realize how much can go wrong for how many different reasons. I won't go through all of this list. I'll read everything. Head and neck trauma, chronic ear infections, maternal drug or alcohol abuse during pregnancy, maternal cytomegalovirus infection during pregnancy, meningitis infection in the child, migraine, metabolic disorders that are not treated, like diabetes, the use of ototoxic drugs, posterior brain tumor, which affects the part of the brain where vestibular input is processed, neurological disorders like cerebral palsy and hydrocephalus, certain genetic syndromes, and the most common are Wallenberg syndrome, Usher syndrome type 1, and Charge syndrome. If there's a family history of vestibular issues, there's some evidence of children being fitted with a cochlear implant, and when the implant is switched on, they develop some level of vestibular dysfunction. It's statistically small, but it does have to be there on the list. And finally, like I said with the proprioceptive sense, lack of use. If there are movement issues, excessive fear and anxiety about movement, or persistent ill health, maybe with hospitalization, then the vestibular system is not going to develop effectively. Vestibular problems may adversely affect many, many aspects of development. First of all, the organization of all sensory information. Then obviously postural security and muscle tone will be affected. And muscle tone, usually children with significant vestibular problems have low muscle tone. That's normally the pattern. Use of vision will be affected, and I'll say more about that in a moment. The reception and processing of sound will be affected. Remembering auditory and visual sequences is likely to be affected. Memory development, especially short-term memory, will be affected. Speech and language development will therefore be impacted because of these issues with perception and processing of sound, remembering auditory and visual sequences, and short-term memory. Bilateral coordination. The vestibular sense plays the key role in developing good bilaterality. Then, by extension, behavior is likely to be affected. Again, by extension, breathing, feeding, digestion, and absorption of nutrition may well be impacted. Sociability may be impacted, particularly because these children dislike being lifted and moved. It has to be done very carefully, and they tend to learn very quickly that people can be a big problem. And finally, self-regulation. Most interesting for me of all is the fact that self-regulation is primarily developed through the vestibular system. So I mentioned the links between vision and the vestibular sense. When people think about muscular activities, they usually think of things like aerobics, weightlifting, swimming, hiking, wrestling, and so on. But they rarely think about using vision, even though vision is a sense that depends upon very good control and coordination of many different muscle groups if it is to be used effectively. So that's a fairly key point when we think about vision. You probably know that we have pairs of eye muscles or ocular muscles, and here's a diagram showing them, and they are the muscles that work in pairs to move our eyes around, so that our eyes can go horizontally from left to right, vertically up and down, diagonally, and we can also move our eyes in a circular pattern, clockwise or anti-clockwise, at will, if those muscles are present and if muscle tone is within a normal range. But because vision is a directional sense, the eyes have to be pointing at something in order to see it. It's not like hearing, where the ears don't particularly have to be aligned towards the sound of the source. It may help if we turn the ears towards the sound source, but we can hear literally with our back to the sound. We can even hear in the next room. But with vision, the eyes have to be pointing at the visual target. And in order to point the eyes, the head has to be pointing, the face has to be pointing at the target, so that the body has to be controlled to enable the head to point the eyes towards the target. So there's a whole range of muscles throughout the entire body that needs to be involved if visual functioning is to be taking place. And vision, in most children, vision drives posture. If the children have very high muscle tone through cerebral palsy, the range of voluntary movement is limited, and this is going to have an effect on the children's functional vision, even if they have no ocular defects as such. So the idea that an ocular defect is what causes visual impairment is long discredited, because there are perceptual difficulties, but there are also motor difficulties which are going to have a very, very significant impact on functional vision and the way vision develops. One particular aspect of the vestibular sense plays a key role in functional vision. This is a reflex that's known as the vestibulo-ocular reflex. And what this reflex does is this. In normal head movement, the eyes move in the opposite direction of the head and at the same speed to stabilize the retinal image. In other words, if you look at a light switch on the wall and then keep looking at the light switch, bend down to the floor, stand back up again, turn your head towards the left, bring your head back directly facing the light switch, then turn your head slightly to the right. It's possible to do all those movements and maintain your gaze looking at the light switch. And it's your vestibular sense that enables you to do that. Your vestibular sense tells your brain when you bend down, when you go down to squatting, the vestibular system picks up that you are moving vertically downwards and tells the brain that the eyes have to move vertically upwards in order to maintain gaze on the light switch. I don't know if I've explained that very well, but I hope that makes sense to you. And I'm going to skip the next two slides because they're a bit complicated and go straight to photographs. So here's a child with significant vestibular issues, with low vision, but now developing an interest in books. The first thing the child does before she's going to use fine vision to look at a book is, first of all, get flat on the floor, then bring one ankle up on the other knee to fix the body, to know that the body's not going to move, so the eyes are not going to be pulled away from looking at the book. And also, the child isn't going to fall. Now, we know if we're flat on our backs, we're not going to fall. But the children need to confirm that because their gravitational insecurity is so significant. So that ankle comes up on the knee. Everything is bound and secured so that the brain is then free to focus on using vision to look at the book. Here's a much older child using some kind of tablet. And again, adopting postures that fix the head, that minimize the impact of gravity, that make everything easier and less energy consuming, and free the brain in order to use fine vision. Here's a boy at one of our picnics. He's been running around with a soccer ball. He's pooped out, he's come back, he's laid next to his grandma. No, first he sat on the blanket and found her cell phone. He immediately rolled down to his back, turned onto his side, brought one ankle up on the other knee, and then with great skill, he's isolating his index finger and scrolling through the phone using his reduced vision. Here's someone sitting on a porta potty. Look at the leg posture. In order to stabilize the body, this kind of contortion is needed to confirm to the brain everything is okay, everything is safe. You can just focus on looking and manipulating the screen on your tablet. Here's another child with a tablet. This is an 11-year-old. We're looking from above, and as you can see, he's over on the back of the couch. This is a very typical position for him in order to use fine vision for specifically for looking at the tablet and manipulating it with his fingers. These postures are seen again and again when children need to free up the brain for using vision. It's good for us to think in terms of, because it's not a need we have very often, needing to free up the brain from other priorities in order to use vision. Here's someone who's got a different posture for the same reasons, planking. And then here's a young man whose mom posted this picture and said when he's doing his homework, he always has to put his hand up and rest his head on it. If you're trying to maintain head position against gravity with low muscle tone and a significantly damaged vestibular system, leaning the head forwards so it's not supported on the spine anymore, the weight of the head creates a big problem. And that hand is needed to keep the head still, because if the head starts to move or drop, the eyes will be pulled away from the homework because of the damaged vestibular system. And what this boy needs, first of all, I think, is some kind of an angled desktop to raise the work up so that he can sit back with his head more erect, balanced on his spine rather than leaning forwards. And maybe before he does something challenging like this kind of homework, maybe he needs some shoulder massage, some head and scalp massage, and maybe some more physical exercise like jumping or spinning or rolling. All those kinds of inputs might make it easier for him to maintain his head against gravity and use vision for the length of time needed. So the vestibular sense tells us where our head is and what our head is doing. If it's not working properly, the brain has that question all the time, where is my head? And we see the children answer the question with things like head weaving, often side to side in a figure eight, binding the head, pulling a hat or a sweatband or even a box or a bucket, a plastic bucket, very tight over the head, wrapping the head in a sweatband or a scarf, holding the head or tapping the head, pressing the head or standing on the head, clenching the jaw, grinding the teeth, biting and chewing. When children bite and chew objects, it's often perceived as oral stimulation, but I think often it's more, to me, like proprioceptive stimulation. It's more a way of answering this question, where is my head, than simply stimulating the oral cavity and the lips. Commercially now, companies have jumped on the bandwagon. This kerchief is produced by a company who know that children with these issues often pull their clothing up and bite and chew on the clothing. It gives them a major sense of where their head is. It helps them to maintain a secure posture against gravity. It helps them to calm down. Sometimes it also may well help them to fixate their eyes more effectively for better functional vision. In the case of standing, more for distance vision. And then there are companies who are producing these kinds of silicon jewelry. So the look of the equipment is less stigmatizing, and they are safe for biting on. This is a girl who isn't just pushing her hands, her fists very tight against the sides of her head, but has now learned to isolate and extend her index fingers to give her a kind of sighting, to help point her eyes in the direction they need to be going. These activities are, as I said, self-taught, and we need to look at them and think, why would she be doing this? And here's a boy who's needing to minimize the impact of gravity, and he's come up with this idea. A beautiful photograph. So what the children are saying is, you fix the body to fix the head, to fix the eyes. So you can use your vision in the best, most reliable, and most comfortable way possible. And then by extension, you can then use your vision for visually directed reach and for fine manipulation activities involving vision in the best, most reliable, and most comfortable way possible, as we've seen with the children operating the touch screen on their tablets. Now, I mentioned balance, and people often call the vestibular sense the balance sense, but that isn't strictly true. Balance or equilibrium results from an interaction of three sensory systems: the eyes or vision, the input from the muscles and joints, which is proprioception, and input from the vestibular organs, which is the vestibular sense. And I've got a diagram to show that. And it's these three sensory systems working together that help us to develop and then maintain good equilibrium, good balance. We know that in more and more of the children in the deafblind population, all three of these sensory systems are likely to be impaired. So it's not surprising that mobility should be affected and walking should be very delayed. Jean Ayres, again, the occupational therapist, this is a quote from her: "When the vestibular system does not function in a consistent and accurate way, the interpretation of other sensations will be inconsistent and inaccurate, and the nervous system will have trouble getting started." Another writer, Carol Stock-Kranovitz, she's also an occupational therapist, and in her book, The Out of Sync Child, she has two interesting quotes. "Gravitational insecurity is manifested by abnormal distress and anxiety in reaction to falling or the possibility of falling. It is a primal fear." And the other quote, "Indeed, our need to know where we are in relation to the earth is more compelling than our need for food, for tactile comfort, or even for a mother-child bond." And this is a quote from Charge Syndrome World. Dr. George Williams, talking about balance in Charge Syndrome. He says vestibular function has a role in detecting head motion, detecting and responding to gravity, providing stability during body movement, locating body parts and developing a good body schema or body image, influencing muscle tone and posture, generally low muscle tone, facilitating the crossing of the midline, motor control, motor coordination, and motor sequencing, assisting with auditory and visual perception, and modulating arousal and alertness for attention and calming. And in an article I wrote about Charge Syndrome, I talk about the early effects of poor vestibular function in children with Charge Syndrome. It's quite a big list: low muscle tone or floppy muscles, poor head control, and poor ability to resist gravity, Strong postural insecurity when held upright or carried around. A marked preference for being flat on the back. Delayed mobility and unusual movement patterns, for example, back scooting, side winding, butt scooting, rolling, and the 5-point crawl. W sitting for a more secure base and to free up the hands. W sitting when the child basically sits in a kneeling position with their lower legs splayed out to the sides. The children show much better visual, auditory, and fine motor skills when they're flat on their back than when you put them in the upright position. They show poor bilateral coordination, and hand and eye dominance is either total from very early on or is missing. And not surprisingly, they show fatigue, trying to resist gravity for periods of time. I'm going to move on and skip some slides. Here's a very important quote from Jean Ayres. After air to breathe, postural security is our next most urgent priority. This quote played an absolutely key role in my development as a teacher and as an observer of children. What Jean Ayres is saying is that if the child doesn't know that their posture is secure, if the child's brain doesn't feel the body effectively, if the child's brain can't be certain that they're safe from falling, that becomes a very urgent priority. And the brain focuses on that rather than other things that we as educators might want the child's brain to be focused on. And again, this quote will come back and back all through these 3 webinars. So early mobility, we see rolling, we see sidewinding, back scooting, what in England we call bottom shuffling, which somebody told me you call butt shuffling in America. The 5-point crawl, and sometimes you do see regular crawling, but that's fairly unusual. And here's a child showing 5-point crawl position, where you've got two legs, 2 arms, and the head as the stabilizing extra point. Walking, the children use walkers. They show a very rolling side-to-side gait. I talked about very flat feet, bent knees, the foot slapping. Sometimes this develops into high tippy-toe walking. The feet often roll inwards and the knees knock together. The arms may be extended to the sides or in front. The fingers may be crossed or the hands may be clenched and fisted. And the eyes tend to be fixed on the visual target. So these children often will get ready to walk, look ahead and fix their gaze on something, and then they will move with their eyes literally holding on, their gaze held by that object. What this means is their vision is not available to check the floor surface and to make sure that things are clear. We've seen some big progress with walking poles with children. This is a young teen in England who had never walked independently. She would only walk holding onto an adult's arm and leaning quite heavily. Her father saw walking poles being used at a conference in America. She lives in London. He went back to England and they got the walking poles, and the girl almost instantly became a completely independent walker and has never looked back. Here she is again in a very difficult visual balance situation. Here's a boy watching television. It's normal viewing when you have no effective vestibular sense, poor tactile and proprioceptive perception, upper visual field loss, and very low muscle tone. I'm going to go more quickly. It's important to respect the behaviors you see in the children and to to learn from them rather than to keep jumping in and trying to stop them doing things. It's good to get an OT and a PT involved, get their evaluation and get their advice. You will need to pace activities to facilitate optimal functioning and to minimize fatigue and stress, both of which are inherent if there are significant vestibular problems. Remember the triangle showing the equilibrium triangle. Any work that improves the functioning of other sensory channels can help to ameliorate the impact of vestibular difficulties. And if you're handling younger children and lifting them, make sure you minimize stress, use anticipation cues, use appropriate speed and direction of movement, and provide physical support for head and limbs. So the child in the picture, if that child had poor vestibular function, that would probably not be a good posture. The child would be more secure, turned the other way, facing the parent in most cases. Always make appropriate physical support available and encourage the most effective postures for functioning, and allow periods of movement or repose as appropriate for reorganization of the whole body and all its sensory systems. These breaks are very important. And some children will need literally to rest, to lay down, even to sleep. Other children will need some bracing physical activity. It's a very individual thing. And finally, isolate lines of text. Either use very large font or a typoscope if it's traditional text. Observe for indications of under-arousal and over-arousal and know what to do about it if the child can't do it themselves. That will be the key theme of the third webinar, in fact, the whole issue of arousal and poor self-regulation. And think about the total demands made on the child by every activity in every situation. In other words, think multi-sensory. Be aware that the child's brain might feel that the body is unsafe. The body is effectively on a tightrope, where we know the child is on a chair and is okay. And it's the child's perception that's going to determine their attentional priorities. Now I'm going to do some more jumping through slides, if you'll excuse me. The brain is connected to the body through the senses. It's only the senses that connect the brain to the body and the outside world. And I believe that most children with deafblindness are not in touch with their bodies and don't feel their bodies very well. 35 years of observing them has brought me to that conclusion. And I found this, I didn't grow up with Dr. Seuss, but I've learned about him since I came to live in the US. And I want to focus on number 3 here, where he says, you have brains in your head, you have feet in your shoes. You can steer yourself any direction you choose. Well, that's true if the brains in your head and the feet in your shoes are connected. But for many of the children we're thinking about today, that connection isn't there. And the ability to steer yourself any direction you choose isn't strictly available to them. And I think it's good to approach children thinking of these 3 levels of communication. It's a different idea of communication to social communication and language. But first, the brain has to be communicating with the body in order for the brain then to communicate with the immediate environment, so that the brain can then ultimately communicate with the wider world. And with each interaction with a child, we might need to go back and check on the first kind of communication each time to make sure the child's brain is communicating effectively with their body. From another article of mine, I talk about children who often adopt specific postures, horizontal with both legs bent and one ankle up, crossing the other knee, legs tightly crossed, fingers crossed or bunched together, hands fisted, arms folded. These postures provide essential, extra, tactile, and pressure information to the brain about where the child's limbs are in space, and also confirms for them that they are securely fixed and not moving or floating around. These postural behaviors, which I've described, have always been present but largely unseen. When they are noticed, there is often amusement because the postures seem weird, or the child is corrected with no attempt to understand or recognize or honor what the posture means and what function it serves. And I'm going to show you more pictures. Here's a child doing this amazing backward stretch, a child with low tone who is then fixing his eyes in this, what to us is a most inconvenient, difficult, and downright dangerous posture. But this isn't about us, this is about him. And he's come up with this because in this position, he's minimizing the risks of gravity, and he's absolutely fixing his head to fix his eyes. Here's a boy taking a break from orientation and mobility training. He's on a little seat having a rest. It's not a good seat. There's no back on the seat. There are no arm rests. And he pushes his fingertips together very hard until the nails turn white, because that posture gives him the extra information his brain needs to know that he's not moving, he's stable, and everything's fixed and everything's okay. Here's a very young child with charge syndrome who's crossing fingers on both hands as a way of getting his brain in better contact with his hands and therefore with his arms. These are very unusual postures to see spontaneously in children of these ages. This kind of posture is often needed for sleep. The brain needs to switch off, but the brain needs to know that it's safe to switch off. So here you've not just got one ankle up on the other knee, but you've got the arms behind the head, a whole extra level of strong proprioceptive input so that the brain knows everything is fixed and secure. It's okay to go to sleep. Here's somebody doing it in a car. Here's somebody finding a way of squeezing and getting pressure. And here, this photo, I love this photo. It was sent to me by Mom. They're at the pool, and this boy who has significant vestibular and postural issues has discovered that his sun lounger has these rubber straps, and he can entwine his legs and feet. Then he can lay back and relax, because that entwining, that binding, is telling his brain that everything's okay and he can relax. And by a small miracle, I come to my last two slides. So I'm going to finish on time. I'm amazed. I know this has all been probably rather overwhelming, but I'm hoping if you're going to be watching next week, and especially in 2 weeks' time, everything I've covered today will come into better focus. I wrote these last two slides for my benefit. I'm an instinctive worker. I'm not an academic. I'm not a great intellect. I say stuff and I think stuff, and it's good for me to think, what am I saying here? What do I actually mean? So this is what I came up with. First of all, everything joins up. There may be many unsuspected influences at work, and therefore sensory functioning depends upon and varies in relation to many, many things. And it's much more complicated than we may have imagined. So visual problems aren't only to do with the eyes, but could be to do with the proprioceptive sense, the tactile sense, and the sense of pain, indeed. There is a fundamental sensory hierarchy to which we are all subjected. Remember the pyramid of development that came very early in this presentation. And that sensory hierarchy is there powerfully for all of us. Vision is a directional sense, so body awareness, postural control, orientation, attention, and stamina are all required. All these are probably compromised by deafblindness. We can help to prepare children to use their vision and hearing optimally by improving these things. With their spontaneous behaviors, especially their postural behaviors, children might be showing us the best way to work with them, the best way to present materials, and the most energy efficient ways to proceed. And what else am I saying today? The importance of getting the brain in better contact with the body for improved postural security. The fact that we can help to prepare children for attention and learning by making sure that their brain is in good contact with the body, by using these compensatory strategies they show us to develop the things we give them, by stabilizing the visual field, by helping the children to self-regulate, and as I keep saying, that will be a feature in 2 weeks' time, by also alleviating, I'm sorry, I've gone out of my slideshow. I don't know if you can hear, but my dog is creating here and making a terrible noise and needs to go out, I think. What a shame. He's been so good all through this session. And I can't show you the last slide, but I'll read it to you. Alleviating physical discomfort and pain from things like constipation or breathing difficulties. Remember the power and the importance of sensory inputs, positioning, and posture and movement. And remember that sensory needs and sensory inputs control and determine attentional priorities. That is the end of my presentation. Again, I apologize, things went a little wrong at the end. I will speak to my dog very firmly as soon as I come offline about interrupting me. And as I keep saying, I think by the end of these 3 sessions, everything will have come together. I'm hoping that today, I wasn't aiming to give you any specific strategies, but I was aiming to show you a way of looking at children and thinking about children and interpreting children that might be very helpful to you. So I look forward to joining you again next week, when the focus will be on assessment, and specifically on capacity assessment rather than deficit assessment. But also I'll be looking a little bit about ways that we can make assessment data more available to people and more interesting to people and more meaningful. So I hand you back to Robin, and I will see you next week.
Thank you, David. You know, I just had to laugh because you referred to yourself as not an academic, and you are much more than an academic. I certainly have heard you multiple times over all these years. I never get tired of listening to you. I always come away with something to use when I see children, and I'm sure all the people today did too. So your dog was wonderful. Your presentation was wonderful. So we will see you next week, and thank you. I want to remind everyone to please fill out the evaluation, and have a good evening, and we'll see you next week. Thank you. Thank you, David.
Bye.
Bye.